Please.
Good evening, everyone. Today, my topic is on role of intraoperative echocardiography in clinical anesthesia. Perioperative echo enables direct visualization of the chambers of the heart and its walls and major connecting vessels. It also provides information about the valve structure, function, ventricular size, function, and hemodynamic status of the patient. Echo can be done using transthoracic echocardiography and via transesophageal echocardiography. Mostly transesophageal echocardiography is done as it is minimally invasive and has a good acoustic window. It uses sound waves to create high quality moving images of the heart and its vessels. It involves a flexible tube with a probe and a transducer as its tip. The probe is guided down the throat and the esophagus. More detailed pictures of the heart is seen as esophagus is directly behind the heart. Transesophageal echo is only performed by a qualified licensed physician. It is done when the nature of the planned surgery or patient's known or suspected cardiovascular pathology might result in severe hemodynamic or pulmonary or neurological compromise, or when there is an unexplained life-threatening situation persisting despite of corrective therapy. It helps in early diagnosis of the etiology of hypotension despite the use of inotropic or vasotrope supports. So what are the indications of intraoperative echocardiography? Intraoperative use is used in valvular repair, congenital heart surgeries for most lesions requiring cardiopulmonary bypass, repair of the hypertrophic obstructive cardiomyopathy, intraop evaluation of pericardial window procedures, intraop assessment of aortic valve function, in repair of aortic dissection and possible aortic valve involvement, endocarditis when pre-op testing was inadequate or extension of infection into the perivalvular tissue is suspected, when there is an intraop evaluation of acute, persistent, or life-threatening hemodynamic status requiring ventricular function assessment. So in transesophageal echocardiography, we look at the global LV systolic function, which is one of the most common indicator of PT examination. It allows to identify those patients who might benefit from inotropes. And evaluation of the RV function should be routinely performed while assessing hypertensive patients. Example, patient undergoing liver transplants are at increased risk of hypotension secondary to RV failure due to the fluid shift. Hypovolemia, which is a common cause of hemodynamic instability, can be assessed by using LV diastolic diameter. Basic valvular lesions can be assessed by using the color flow Doppler assessment, and stenotic lesions by using the leaflet motion and Doppler motion. Venous air embolism, which is most commonly seen in craniotomy positions in sitting, can be easily visualized. It is most sensitive as high as 76%. It can be addressed before it becomes significant and helps in diagnosing and treating embolisms. Hemodynamic and other psychological risks during the perioperative period increase the risk of periop MI, especially among patients with CAD. In these patients, regional ventricular dysfunction can be assessed, and it can be addressed earlier in treating the patient. Multiple reports support the use and delineate the impact of transesophageal echocardiographic guidance and intraop decision making. Incidental finding plays a large role in this impact and significantly influence the patient's surgical procedure and outcome. What are the contraindications? Contraindication, it is absolutely contraindicated when there is a perforated viscous or esophageal stricture, tumor, or perforation in the esophagus, or when there is an upper active GA bleeding. What are the advantages? It has a transducer which is 2 to 3 mm away from the heart, and it is closer to the posterior surges. So better visualization of the lateral ventricle, left atrium, mitral wall, left ventricle, and aorta can be seen. It is far from the surgical area, so intraop monitoring can be done. High resolution images can be seen due to the absence of intervening lung or bone tissues, and better signal to noise ratio and decreased image depth. The disadvantage is it is a semi-invasive procedure and needs special setup, technique, and preparations. Need expertise, orientation, and needs orientation and expertise. Thank you, sir.
Finished? Okay.
Yes, sir.
So this question is actually a modified way of asking about transesophageal echocardiography. Because intraoperative echocardiography monitoring, most of the times we will not be able to do it in the transthoracic way as we do for a routine echocardiography in the cardiology groups or outpatient. So most of the time it will be only transesophageal will be possible without interfering with the surgeon's work or the surgical field. So it is an indirect way of asking about transesophageal echocardiography. So we have mentioned all the indications, contraindications, and all these things. I think you have to mention some more about the complications and at what levels you have to do that. And what are the structures you are able to identify and how it is useful. Because they are asking about intraoperative monitoring with echocardiography. I'll just show you how the presentation can be.